Let's talk about diabetic ketoacidosis. Let's review insulin and blood glucose. In a healthy cell, insulin and blood glucose have kind of a good relationship. The pancreas makes insulin, and insulin is like a key. And there are these little doors on the outside of body cells, right? And these little doors need to be opened by a key called insulin. So insulin gets sent through the blood to the cells, to these doors, so that this sugar that's floating around in the blood can go in open doors into the cell where it gets utilized properly. In type 1 diabetes, the things going on inside of the cell that are supposed to happen with the sugar don't happen as well because we don't have insulin being produced by the pancreas. So that's type 1 diabetes. Type 2 diabetes, there's plenty of insulin being made. It's just for some reason it's not working to open up those doors. So the functions that are supposed to go on inside of the cell have a hard time because the cell isn't getting the sugar that it needs. It just builds and builds and builds in the bloodstream. That's type 2. All right, here's the ketoacidosis definition. A metabolic acidosis from the use of fats for energy instead of glucose. Glucose is greater than 250, bicarb is less than 18, pH is less than 7.3, and there's ketones in the blood and the urine. Now, in ketoacidosis, it's all about what's happening in the cell. The body wants to try to make energy in its cells, but it just doesn't have the key. The pancreas, oftentimes it's a type 1 diabetes exacerbation, and the pancreas is not making insulin. Something in the body triggers this, some kind of stress situation, and the sugar builds and builds and builds in the blood, but it's still not going into the cell. The cell is absolutely locked because we don't have these keys to get the sugar inside. As you can see, the cells of the body remain locked up like Fort Knox. So with the cell all locked up, you would think that the cell wouldn't be able to get any energy. But our bodies want to survive, and our cells want to survive. And our bodies and cells are smart. So they find a way to survive. And they survive by using fats for energy. Okay, and when they use fat for energy instead of glucose, they still make energy, beautiful energy, but they get byproducts like ketones, which makes the blood acidic. These ketones will build and build until they start to spill over into the urine. You'll be able to smell these sweet ketones on an individual's breath. You'll be able to measure the pH by getting someone's pH from their blood gas. Potassium will be elevated because potassium sees what's going on out there and it actually wants to join the party. So it elevates out in the bloodstream a little bit by slipping out of the cell. That glucose just keeps building and building and building and building and building, and it gets very, very high in the bloodstream. And building and building. Signs and symptoms: sweet, fruit-like scent to breath. Okay, excessive thirst and urination, nausea, vomiting, abdominal pain, Kussmaul's breathing pattern. We'll talk about that. Shortness of breath, confusion, and lethargy. Laboratory levels are needed in someone who is suspected of having ketoacidosis. We need to know their blood sugar. We need to know their potassium. We need to know their ABG, their pH, and their bicarb. And if they have urine ketones and sugar in their blood. So let's sum that up. Bicarb, less than 18 milliequivalents per liter. pH, less than 7.3. Potassium is often high, greater than 5.5 milliequivalents per liter. Blood sugar, so blood glucose is usually greater than 250 milligrams per deciliter, but sometimes some sources say 300. And then urine and ketones are both positive in the urine. All right, so now let's talk about treatment. So treatment should be done very carefully, starting with fluids, okay? We usually start with normal saline, and then we go to a half saline product. Sometimes there's potassium in it, and sometimes not. Then we use insulin, and we're very careful about the insulin and how fast we bring that blood sugar down. We don't want to do it too fast. There are always risks associated with that, including risks involving swelling in the brain. We want to monitor the heart and electrolytes. Again, potassium before treatment goes out to party, but once a person gets treated for this, the insulin allows that potassium to slip back into the cell with the sugar. So it can drop, and it can drop quite rapidly. So watch those really, really, really closely. And then assess breathing, support breathing needs, assess the patient, and you've done a great job. Collaborative interdisciplinary treatment includes starting normal saline or lactated ringers for at least a liter, and then half normal saline, followed by an insulin drip, nice and slow, K replacement, so potassium replacement if necessary. Monitor all of those electrolytes, okay? Assess and intervene for respiratory needs. In very severe acidosis, sodium bicarb is sometimes given. Great job. Let's go to Kahoot and see what you learned.